harm reduction just on a fundamental level is just common sense. It's about keeping people safe. And if one accepts that to some extent the preservation of life is perhaps the greatest value we live by, and that the preservation of health is closely related to that, harm reduction means it's about keeping people safe. And it especially applies to keeping people safe when they are drawn to, for one reason or another, engaging in risky behaviors. So harm reduction is bicycle helmets and motorcycle helmets. Harm reduction is seat belts. Harm reduction is safer roads. Harm reduction as clean needles rather than sharing, needles that are no longer sterile. Harm reduction as naloxone for people who may overdose. Harm reduction as really anything that helps to reduce the risks of activity that human beings engage in.
There's something very powerful about saying, I want to save your life, I don't want to fix you. And just giving somebody a clean needle or something else that will just help them in what they want to do often opens the door for larger transformation, because people start to feel more valued and feel more worthwhile and feel like, well, somebody thinks I deserve to live. Maybe I should investigate this more. And you also see a lot of times people who do needle exchange or work in needle exchange programs are in recovery themselves. So the people who show up for services are like, well, how did you quit? And that opens the door. So there's many different ways that it can be a very, very powerful way to help people. And even if they never get into recovery, a lot of times people who become engaged in needle exchange will dramatically reduce the harm around their addictions, because they feel more valued and because they have the tools that they need to protect themselves.
Well, this is our syringe exchange. Yeah, this is kind of how it starts. So people will come in here, they'll grab a bag, and they'll take whatever they need from here. Up here, safer sex supplies, and down here, safer injection supplies. You have the gauze, the cotton, 2 different types of cookers. Lots of different types of condoms, also flavored lube and regular lube. Out here we have a lot of just kind of information, some of it that we make, like mainly our safer injection guide, but also other resources that other people can access from other places, other community partners, stuff about the actual drugs that people are using. So it's kind of like a catch-all for a lot of stuff. In here, most people will come right through our doors and come straight in here to access syringe exchange services, and they'll show us their syringe exchange card with their code on it. This is a blank one. And if they have dirty syringes, they'll end up in here. And if they're used syringes, they have lots of them in a box or in a sharps container. They'll end up right in here in this basket. And so mostly people will come in and ask for whatever type of syringes they need. And the person who's working in here, either a volunteer or intern, sometimes I'm in here, and they will get, these are the most common syringes, the half cc's. So we usually give these out 10 at a time. Some other syringes that people enjoy are the blue tips in here. The tips used to be blue, now they're orange, but people like to pop the cap off of them, and so they can fill it with other stuff. And then some of the other syringes we have are the 3 cc's, and these are mostly for people who are utilizing intramuscular shots. So if you're shooting steroids, or you're shooting methadone, or any kind of sort of like hormones, at least for our trans clients, or these are big amongst that population. All the services are free of charge and anonymous. Some of the other things that we give out are hygiene supplies. And so it makes a difference to tell someone, hey, it's a good idea to safely inject, clean the wound pretty clearly, swipe alcohol in the right way, do all of that stuff that we teach people, but not have a place to shower, brush your teeth, or things like that. So we give out basic necessities, soaps, combs, tampons, antibacterial wipes, things like that. Other stuff that we give out outside of just the safer injection, that stuff out there, we give out actually like ties. People can tie off right because this can also become a source of contamination for folks. Bleach kits are not out there. Bleach kits are to use to clean the syringes, and so it's 3 times with water, 3 times with bleach, and 3 times with cold water again, just in the case that someone has to reuse a syringe. I would say majority of the stuff that we give out in the syringe exchange is tea. Most of the people who just come here just to get tea or whatever for the case. It's a really popular service, and also comes along with conversations about what's going on in people's lives, but also anything that has to do with that's particularly related to our population. So the person in here will talk about Hep C transmission or Hep C prevention, HIV transmission, how to get a Narcan kit, so that way not only is a place you get syringes, but you also have an opportunity for engagement and also to get you into other services as well. And so this is kind of the entry point for a lot of people. I would say a lot of our participants kind of stay in this area, but when they do sort of make the transition from syringe exchange over to other services, this is often the space that happens before.
When I was in college at Columbia, I became an IV drug user, and I had been involved with cocaine for a while. I got interested in heroin and immediately loved it, and very rapidly got into injecting. And this was in the early to mid 80s, which was probably about the worst time you could get into such a thing in New York City. Around 50% of IV drug users at that point were HIV positive already. So I was putting myself at great risk, and what was incredibly lucky for me was that a woman from San Francisco was visiting a friend of mine that I had gone to COP with, and actually he went out to COP and we sat at the apartment. But while we were waiting for him to return with the drugs, she told me that I was at risk for HIV and that I should never share, and that if I had to share, I should use bleach, because this was before there was actually needle exchange. It was at the time when people were just, at least in the United States, people had just started to think about, what to do about this. And there were all kinds of myths about how, addicts like to share needles, and all kinds of other barriers towards doing something about this massive public health problem. So thankfully for me, she taught me that day how to protect myself, and I did that until I eventually got into recovery. And she saved my life. I mean, there's no doubt about it. That guy that actually had gone out to score at that point, he became HIV positive. I'm not sure what became of him, but I know that several other people that I used with were definitely infected. So there was no doubt that I was at very serious risk. I was so in awe of people like Alan Clear, who is the director of Lower East Side Harm Reduction, and the other people who were, out there on the streets actually doing this, risking arrest, going out and making this happen.
Hey, can I help you?
Sure, I need it as 10 cc's.
10 half cc's? Can I have your code?
AGS 23. And I need a little bit of information on how to use this again.
Okay. So you said 10 half cc's.
I don't have a bag.
Okay, you can grab a bag right there. Okay. Here you go. Do you need alcohol pads, Band-Aids?
Please.
And you said you needed some help on how to safely inject?
Yes.
Okay, so what are you doing now?
I intravenous for you in the arm, but I know it's sending in a lot of sores and abscesses, and I don't think that I'm doing it quite well.
Okay. And when you're actually injecting, what are you actually doing? Are you how to show me your process?
I just take a tie and tie it up,
Okay.
and just like that. I don't clean it or anything. I don't even really know how to use the alcohol safely at all.
Okay. So when you get your alcohol pads, you rip them up one direction, and you're shutting right into the veins. And so I can show you. Do we have those things? So this is my little practice pad.
Oh, great.
Practice pad. And so one of the things that you can do, particularly if you're injecting, are you injecting it into your arms?
Yes.
Okay. Are you rotating your sites? Like, are you changing every few days? It's the same?
It's when I can't get it any longer is when I change.
Okay.
Do you think that's where the abscesses could be coming from?
Yeah, the abscesses are definitely coming from that, particularly if you're using the same syringe, if the syringe is dirty, has been placed down other ways. Also, if you could have exhausted the veins yourself. And so I don't know how long you've been injecting, but if you've been injecting for a while.
Less than 6 months.
Less than 6 months, so you're brand new. And so the thing that I tell people is that, do you know when you actually hit the vein? How do you know that?
Because sometimes the blood will flow back, but sometimes I don't. So I get them moving it around and then it moves.
Okay. So I tell people if they don't hit the vein right away, take the needle out. So that way you can either use a new needle or you can definitely try again. But the moving around that may destroy the vein, but you'll definitely know because the blood shoots right back out of it. Okay. And so making sure that it's a 15 degrees. So this is my needle, making sure that it's just right into the vein. Because the blood will shoot back out. And some people wait for it to mix. If not, it's definitely your choice. But then you sort of push it back in. Okay.
I surely wasn't doing it that way.
And it might take a while for you to get comfortable with a method that works for you. And so I would definitely say try to identify the vein as much as you can, like making the tourniquet a little bit tighter. Right. Flexing, try a different spot. Arms, your legs, and things like that, because you can prevent from getting sores and things like that. Make sure if you can not to reuse a needle as well, like throw them away immediately. Okay. Yeah, and if you can take a break, for a day or two, that could also give you some healing time. Using like the Band-Aids and the bactritration wipes and things like that can also help or cover up the area, so it can, particularly if it's an open sore, I wouldn't suggest. Yeah, no problem.
Some people might be concerned that if they have a needle exchange program operating in their community, that they're going to have a lot more syringes in the community and a lot more syringes discarded on their streets. The actual research tells us that the opposite of this is true, that drug users are very good about bringing in their syringes for proper disposal if they have a place where they can properly dispose of them. Last year in 2012, we collected almost 250,000 used syringes that otherwise would have been discarded on the streets. Studies have been done to compare cities that have syringe exchange with those that don't have syringe exchange. Miami and San Francisco were compared. Miami has no syringe exchange, and in Miami, 4 times more used syringes were found discarded on the streets than in San Francisco, even though San Francisco has twice as many drug injectors. So it's about an 8-fold difference. So if you have a syringe exchange operating in your community, it's actually serving to get the used syringes off the streets, getting them properly disposed of so that you or your children, your pets, won't accidentally get a needle stick by a discarded, contaminated needle.
Outside of our agency here, we have a kiosk, a drop box where people can drop off used syringes 24 hours a day. Last year in 2012, we collected over 60 pounds of syringes in this drop box, and that corresponds to over 12,000 used contaminated needles that we got off the streets. Here's where people can drop in their used syringes when they're done with them and need to dispose of them safely, and they will be shipped off for proper biohazard disposal.
Long-term recovery involves, and you see this beautifully actually in some harm reduction settings, that people in some ways need to claim an identity that's other than that of an addict. So I started my career down here in the Lower East Side. I started at a methadone clinic relatively close to here. And one thing that struck me was many of these patients I treated were addicts 24 hours a day, which maybe sounds obvious, but it was striking to me. That they said to me, The only person I ever speak to who doesn't use drugs is my mother. All conversations are with people who are using drugs. So their whole world had collapsed down to something so narrow and so small. But to get better, they need to become something other than an addict. And they need to find some sense of self and some sense of connection, some sense of place that competes with and replaces that of being an addict, that's reinforcing, that's meaningful. Now, certainly you see, and you're seeing this, I think vocal is a great example, which I think sometimes hangs out here, and harm reduction, needle exchange. If I become a needle exchange worker, I go out on the streets. Well, now what am I doing? Well, now I may be still an active user, but I'm also a peer counselor. I'm also an HIV activist. I'm also, I'm showing up someplace. I'm wearing a vest. I'm giving out stuff. I'm getting more complex.
Why do you think it's important to do outreach with Syringe Exchange?
It's better for the drug addicts that are scared to come into the exchange to get help, and it's for us to bring it out to them, because a lot of homeless people really don't like coming forward and letting people know their business. So this way it's much easier to help out the drug addicts that really don't want people in their business and do the syringe exchange with them.
Do you give out anything besides syringes?
Hygiene kits, razors, washcloths, socks if you have them, t-shirts, hats, stuff like that.
Do you find it rewarding to do outreach?
Oh yes, exactly. I love it. It's real rewarding. It's a real rewarding job to help somebody else out.
Why? Can you tell us some more?
I used to be a drug addict myself. I'm clean now 7.5 years, and when I was out here, it wasn't out here. So now that I'm clean, I'm able to give back to help.
The storefront, outreach, and peer delivery are all a part of the needle exchange program, but they all reach different communities. The storefront is here at 25 Allen Street, and it's from here that we really refer participants to services in-house. But outreach and peer delivery really feed into the storefront. Outreach and peer delivery, it's about being the eyes and the ears on the street. We hear from participants directly their needs, and then we're able to take that information and share it to a lot of the people that come through the storefront. So for example, on outreach and peer delivery, we might hear about certain drugs that are out on the streets, particularly drugs that people are having really bad times with, such as they're experiencing overdose, that it's cut with certain things. And when we hear those messages from participants on outreach, we take that information and post it in the needle exchange to be able to inform everyone about it. What makes peer delivery unique is that we seek out leaders from within our participants, people who are picking up and dropping off large numbers of syringes, like 500 to 1,000 syringes. And that kind of gives us a moment to question them and ask, are these all yours? And when we ask that question, we find out that no, it's not just theirs, but it's a part of this whole social network that they're a part of. And so from engaging those participants, we asked them if they'd be interested in volunteering with us to do syringe exchange and give back to their community. And oftentimes they are, and we expose them to training curriculum on HIV/AIDS, harm reduction, syringe exchange, outreach. And then if they're a good fit for our program, they become interns with us and kind of do this work for their community.
I came here about a year or two ago, and they had a program called peer-to-peer counseling, and I took it. And once in it, I felt, I'm gonna give it back. I'm gonna take what was given to me, and I'm gonna take it back out there to the streets, and I'm gonna try to save my brothers' lives.
Besides syringes, we offer safer sex supplies, education. In the winter time, we have in-kind donations of socks and winter gear that we hand out to our participants. We make peanut butter jelly sandwiches, so nutritional supplies to our participants, all that good stuff. And all these are really tools of engagement to build relationships, to build trust with these communities, so that they can feel comfortable enough to come down to our drop-in center and then access services, whether it's case management or therapy or psychiatry.
They would help with housing, but I just didn't know where to go.
You gotta go to that spot right there, 25 Island. Like she said, you walk up First Avenue, and there's a 25 Island. It's on the left-hand side, right?
The story. Now I realize that you got stories in the fucking
That's original though, you heard? One of my favorite parts of my job is when I see our peers and interns move on to bigger and better things. And we've actually had a really good track record with job placement within the field of HIV prevention, harm reduction, after they've completed their internship here. So much work goes into getting to that point when they're ready to leave. Not only the work experience that they gained, but being a part of this community and kind of holistically improving their lives.
The idea that if we break you down and just make you feel really awful about yourself, you will want to stop, completely misunderstands why people use. Confrontation attacks people who already feel horrible about themselves, and it shames people who already are terribly ashamed of themselves, and those feelings actually drive a lot of the addiction. So when you're increasing the feelings that drive the addiction, you are pushing people to use more. You are not pushing people to get into recovery. People who have drug problems need hope, and they need to feel connected to other people, and they need to feel that there are alternatives to drugs that will allow them to feel comfortable in their own skin. And if you don't provide those alternatives, it's very difficult to get people to get help.
There's a traditional view that active drug users can't benefit from psychotherapy. They need to be abstinent before they start therapy. How do you feel about that?
Oh, I think it's bogus. I think it's just so limiting for both the therapist and the client. I mean, the simple fact is it's just not true. It's just not true that active users are benefiting from psychotherapy. They are showing therapeutic gains even if they're continuing to use. There are ways to work with active users where they can be present for sessions and do the work and make progress.
Do you encourage active users to try not to be too intoxicated when they come into sessions?
Yeah, that is kind of one of the pitfalls. I mean, it depends because, some people need to be intoxicated just to function. So it's a very kind of case-by-case basis. But if you're intoxicated to the point where you're nodding out and you're not able to engage, then the work probably becomes more around how can we help you allow you to be more engaged? Or in other words, do we need to set a different time for your sessions? Do we need to have our sessions on different days or at different points according to whether you go to your program or just whatever you need, whatever you as the client need to be able to be present.
Do you find that participants, some of them want to work on drug use, some want to work on mental health, some want to work on both together?
Yeah, it's an interesting variation of goals that are set by clients, and not everybody sees their drug use as the problem. Sometimes what the problem they see is the problems in their relationships, or the problems in their finances, or the problems in their home life, or the problems in their past, and so they don't necessarily identify their drug use as the problem to be working on. So they may set different goals, and there's a lot of variation there.
What are some of the basic principles of harm reduction psychotherapy that you use with participants?
Okay, being where the client is. excuse me, being where the client is which is basically, it's, you know, it's just good social work practice. It's not just harm reduction practice. Allowing the client to set the treatment goals, allowing the client to identify what progress is going to look like. So not setting that agenda, not coming in right away with thinking sobriety is the ultimate goal. It may not be the case. And looking for ways in which their behaviors even now, even the drug use, is serving a positive function, and honoring that and respecting that. You know, they're survivors if nothing else. So I think that's it's important part of harm reduction it's important part of harm reduction psychotherapy is to look for the strengths, and the main goal should be to empower clients to make better choices that will improve quality of life as well as reduce harm, and never having that agenda of abstinence only.
Now, aren't you afraid as a pregnant woman to come here and work with people injecting heroin or smoking crack or things like that?
You know, well, this is my second pregnancy here, if that's any indication of how relatively safe I feel. It's an apprehension that I can understand. I think I felt that apprehension more when I was first starting as an employee, when I wasn't pregnant. I had not worked with substance use before coming here, and so just working with a new population was daunting in and of itself. But being pregnant, no, I gotta say, I do get asked that a lot, even by some of my doctors, and I feel quite the opposite, actually. I kind of feel like if anyone understands the value of new life, and it's our participants. I feel like our participants are, for the most part, people who would give anything to be able to start over, who would give anything to be able to go back knowing what they know now and make different choices for themselves. So I think when they see me and they see new life and that potential there, they honor that, and I think they also value the innocence that comes with, you know, being a child, and the sense of, they have a very acute sense of justice, I feel, more so than other kinds of populations. They have been at, and they continue to be at the short end of the stick. They have the most stigma attached to them. They're the most oppressed of the oppressed. So to see me and this kind of like innocence of like a pregnant woman and what that embodies for them, they want to protect that. So I think, you know, for every chance that there might be someone out there that may be volatile and suddenly become aggressive or try to attack me even verbally downstairs, I would say there's about another 20 to 30 people down there that are gonna jump in and rescue me and protect me and not let anything ever happen to me, because that's just the amount of integrity that they have. And it's really a sad thing that just because they're drug users, people don't acknowledge that about them.
As a psychologist, I finished my clinical training and got my first job in a multimodality drug treatment program up in East Harlem back in the early 80s. And at that time, the disease model, abstinence-only approach to treatment was really the only game in town. And so I learned that approach and worked in a series of different jobs through the 80s, ultimately becoming the clinical director of a few programs, one a premier intensive outpatient program, working under the disease concept abstinence-only approach. And through the course of those years, I discovered that looking at our outcome numbers in these various programs, that the majority of people that came to treatment didn't stay. Or we had to discharge them because they didn't stop using. And from an abstinence-only perspective, abstinence is the only measure of success. It's frequently a criterion for getting into treatment, or at least a commitment to abstinence. And so I began to look at the numbers and notice that the overwhelming majority of people who were coming to treatment weren't staying, weren't stopping, weren't completing, and began to feel with an increasing amount of concern and confusion that this dominant treatment model wasn't helping most people. I then began to look at the numbers and essentially began to see that in the literature that seemed to be the standard. And even taking a bigger look, noticed that the majority of people with substance use problems were not even going to treatment. So that led me to begin questioning, kind of what was wrong with the model. According to that model, the failure is typically explained as relating to, this cunning and baffling disease of addiction, or the patient's lack of motivation. And I began to feel that that was just sort of blaming the patient for the failure of the treatment, and wondered sort of what's, the limiting factor in the treatment model. And what jumps out is the abstinence requirement. This is now going into the late 80s, early 90s. I began experimenting with, in my own private practice, treating substance users who were actively using, who were not willing, able, or ready to stop using. And in contrast to what the model predicted, many of these folks got meaningfully involved in treatment. Many of them reduced their use. Many of them stopped. So my clinical experience, once again, in private practice, challenged this set of expectations related to the traditional approach.
Do you think that at Lower East Side, that we can engage people in psychotherapy that have not been willing to seek it elsewhere?
Yes, absolutely. Absolutely. I think we are incredibly unique in a sense that, just starting on the premise of you don't have to stop using. We don't even need to talk about your substance use. And I think that so often, the precedence in the country of addiction treatment is that you have to stop. And so there's this idea that that's what you're going to get. But with us, we put that, I know I put that out there right away. I know you're coming to a harm reduction center, so that implies that your drug use is a part of your life in some way, but that doesn't need to be the focus of our conversation unless you want it to be. And I think that puts people at ease.
Right. When you ask them what brought you here today, I don't go in with an assumption about use being what brought them in, even though it is a harm reduction center and they might have engaged in our services through another avenue, outreach or a needle exchange or a community meal. I never assume that what brought them into therapy is their substance use, unless that's what they tell me.
Yeah.
Is everyone that you do psychotherapy with an active drug user?
No.
A lot of times I work with individuals around maintaining sobriety, or kind of figuring out how to use maybe one substance while they're actively not using another. That makes any sense.
So they might quit heroin but still drink socially sometimes?
Yes. Yeah,
definitely.
So here we have a dominant treatment paradigm that is not fitting the data. And I began to look around for other models to explain the data. In fact, that is the failure of the traditional approach, and the fact that working with active users was actually helpful to many people. I had the good fortune to have a close relationship with Alan Marlatt, who we might consider as one of the godfathers, was one of the godfathers of harm reduction in the world. And I shared with him my quandary. And this was in 1993. There was this sort of seminal moment when he said, "You're doing harm reduction." I had never heard of the term before. He introduced me to this new paradigm, and my career took a 180-degree turn. Suddenly, that was my spiritual reawakening. This new paradigm, as far as I was concerned, explained the failure of the traditional approach and offered a whole new vision for understanding why working with active people is not only possible, but essential for the majority of people with drug and alcohol issues and other risky behavior.
Well, harm reduction is the idea that we're not going to get everybody to cease using drugs or alcohol. And of course, by indicating that things besides drugs and alcohol are involved in addiction, it makes it even more evident. You're not going to give up eating, for example. You're not going to give up, in the terms of love and addiction, you're not going to give up relationships to get over addiction. So abstinence is an extremely small corner of the recovery spectrum. Harm reduction really deals with everything else, the entire range of other responses. Ways of improving your life and reducing the harms from your addictive involvement to a lesser degree, to a more manageable degree, perhaps eliminating them entirely with continued use, or perhaps eliminating it entirely through abstinence. Harm reduction recognizes the reality of substance use and a panoply of responses and possible positive outcomes.
Well, historically, harm reduction was a grassroots movement, I guess in the 1980s, really, in Amsterdam and Liverpool, or the Netherlands and Liverpool, starting there. And, then so spreading through Europe with HIV/AIDS, and then Edith Springer and Alan Marlatt, I guess, are the two people usually associated with bringing it to America. And I think many psychotherapists who were in the mental health tradition of cognitive behavioral psychodynamic approaches to addiction saw an opportunity there because they saw this was an approach to addiction that fit the humanistic spirit of our psychotherapy and also gave us a way to work with people who are actively using and dance between, let's talk about the use, let's try and keep people safe, and let's, but there's pain here or there's suffering here, and to see addictions as complicated. So I think they work very well together, or at least in that kind of mixture, they can work quite well together. Again, not everybody who's a harm reductionist is a psychotherapist, but I think this was an interesting meeting of therapists seeing something in harm reduction, saying there's something here for me to use that can be helpful with my patients, and this attitude of I don't have to force them to get better. I'm not responsible for all that pressure that's on people in traditional recovery, traditional treatment. We could put that pressure down and go, okay, let's just start. Let's just be here. So that was, I think, a great sigh of relief for psychotherapists also.
So I understand that you're here because you want to do the Narcan train?
Yeah, I'd like to learn about that.
Okay, so do you know anything about it at all?
Well, I heard it reverses overdoses.
Definitely does, but opiate overdose only.
Nothing else?
Nothing else. Nothing else. But a lot of people nowadays, they mix drugs. So if you're not sure what they overdosed on, it's okay to administer it because there's still, up till today, there's no statistics stating that it will cause any harm if it's not an opiate.
Okay, so it doesn't have a problem of interacting with other drugs?
None at all. And if it's a medical, like a heart attack or something like that, it doesn't interfere with that either, as of yet. Okay? So, let's start off by, let me ask you, have you ever seen an overdose?
No.
Do you know what an overdose looks like?
Well, I've heard my friends talk about them, but I've never seen one myself.
Okay, well, a person that's in that stage usually is non-coherent, unresponsive, the eyes may be flipping up, foaming at the mouth, raspy breathing, and turning purple. because basically oxygen is not getting into their lungs. Okay, that's what an overdose is. It shuts down the brain so that the oxygen does not go into the lungs. Okay, so let's say you see that situation happening, right? Do you know why people have overdoses?
Well, I think it's because they take too much of the drug.
A lot of people overdose because they either go to detox or they go to jail and they come out and they use by themselves, or they mix drugs, or they think that they can use the same way they did before they stopped using. So that's what causes an overdose. And a lot of people that come home from an institution or from a rehab don't tell anybody that they're using again because they're embarrassed or ashamed to let their family members know they use by themselves, and then they overdose because there's nobody there to help them.
LES was one of the leaders in espousing the need for naloxone as a substance which could readily be available to reverse a potential overdose. And just in the past year, we trained nearly 500 people in the appropriate use of both intramuscular and intranasal naloxone delivery. And we saved nearly 40 people from death.
This is self-explanatory. This is a mask that you put between yourself and the person to ensure that whatever the person has or you have, you're not trading anything. Okay, so it's placed over the mouth, pinched here, blown twice in the mouth. Right? Make sure that the person is laying flat on their back. Check the airways, make sure there's nothing in their nose or blocking their mouth. Place the mask over and give 2 breaths, right? Then what you're gonna do after that, you're going to take and repeat it, going 1 Mississippi, 2, 3 to 5, and try it again. Okay, for 2 to 4 minutes. If that doesn't work, you'll go back in the case that we give you, which is this bag. You'll find a syringe, and a bottle. The bottle will have an orange cap on it. You will remove the cap. You will take the syringe. You will push this green part down, take off the top, turn the syringe over, place it in the jar, take all the liquid out of the jar. You will look for the person's muscle in the arm or in the leg, in the thigh. Find the muscle. This is a very large needle. It goes through the jackets, sweaters, so you don't have to remove them, and it goes through your pants also. In one quick shot, let's say this is the muscle. One whole thing straight through, all of the liquid into the person. All right? You will take this green cap. You will close it. It will lock it so that nobody gets stuck with the needle. Okay? Since this is my sample, I will put this back on it. But if you clip this, you'll hear it lock. You don't have to worry about it. Then you will see if the person responded. If not, you will go back and do the rescue breathing again. From 2 to 4 more minutes. And after that, you will take and repeat the process again, because there'll be another bottle and another needle. And you go through the procedure again. By that time, hopefully the EMS workers are on their way and there'll be help, or the person will have revived and came back around. They're going to be angry when they get up because it reverses an overdose, so it makes the person sick. So if the person is on heroin or opiates, they will be sick and withdraw. They're not going to be happy. Do not let them use again, because the Narcan runs out in 30 to 90 minutes and they can go back into an overdose state if they use again. Okay, so tell them to follow up with the EMS workers and try to get them to go to the hospital. If in the case that you cannot wait for the EMS workers to come, or you're not comfortable, you don't want to wait, put the bottle, either 1 or 2 depending on how many doses you use, next to the body. Place the body on the side and put the hand over the other hand and one leg tucked up so that way, in case they start throwing up, they will not choke on their vomit. Okay, do you have any questions for me?
I heard there's also naloxone that goes in the nose.
Yes, we have the other one. Those are for people that choose not to use syringes, or not everybody's okay with using needles. And if you travel a lot, it's better to keep the intranasal, which looks like this. It'll be, instead of the needle, it will be this red bottle. Oops, sorry. This one. And this. It will have two of everything that's right here inside the case. And what you will do is you'll take this you'll open this first. Take the yellow cap off. Put the nose piece, twist it. Take the bottom yellow piece off. Take the red cap off the other bottle. Put it in until you feel resistance. So if you grab this, you can feel the resistance. Try to push it up. See how the resistance is? Okay. You will take half, make sure there's nothing blocking the nose, half in one nostril, right? Half in the other nostril. And sometimes we're nervous, we're not gonna make sure that we don't know what's half for sure. If there's any left in the bottle, go back to the first nostril and administer it. And do the same thing, and then do the rescue breathing again for 2 to 4 minutes. If that doesn't work, take out the other dosage that's in there and use the second dosage. Okay, so whichever one you're comfortable with is the one that we will give you. If you travel a lot, I suggest that you do the intranasal, or if you're a little squirmish around needles.
So I understand you're interested in an HIV test.
Yes.
Okay. Well, welcome. Do you have any questions before we begin?
No, just a little nervous, but I'll be okay.
Okay, we'll make sure we take care of that. I first want you to take a look at this paragraph. This is basically letting you know that the testing is confidential. This is you giving me permission to test you, and letting you know that no one can discriminate against you based on the fact that you're getting tested or whatever the results might be. Okay? So if you just take a look at that, and you can sign on the inside. I'm going to get the test started, and then I'm going to ask you a series of questions to determine your risk.
Okay.
This is a standard oral HIV test. Have you ever had one before?
Yes.
I'm just going to ask you to put this in your mouth. You want to move it around against your gums and cheeks and make sure you get it as wet as possible. That should be good. In 2012, we tested about 516.
Okay, and how many positives did you find?
In that time period, for that contract year, we tested about 3 people tested positive.
Okay, that's not very many, but is it a good thing that you have a lot of negative tests?
Even though all of our trainers are extensively trained in how to respond to a positive test or preliminary positive test, the low number of positive tests actually speaks to more of the work that our agency's been doing on the whole. Our syringe exchange program allows folks to get brand new needles in exchange for ones that have been used, and that has significantly decreased the number of folks who are getting HIV by way of intravenous drug use. With our Street Smart program, as well as our other programs that have a focus on prevention, we've seen a decrease in the number of folks who are testing positive and an increase in the number of individuals who know where they can get tested, who are aware of their status, and are able to speak rather comfortably about knowing their status and knowing where they could go if they needed an HIV test, which the easiest place for them to go would be right here at Lower East Side Harm Reduction Center. This is your test, and your test is negative.
Whew.
Okay. That means that from 90 days ago, you have not, 90 days ago and before, you haven't had any contact with HIV.
Okay, great.
Now, there's a window period, and so I'm going to ask that you come back in about 90 days to be retested just in case.
Okay.
Okay?
Okay.
Do you have any questions for me?
Yeah, in those 90 days, what should I do to make sure that that test is a test that I don't have to repeat again after 3 months?
Okay. If you're able to use barriers when you have sex in that 90 days, or have sex with partners that you know are negative, that will ensure that the test that you take in 90 days will be a true negative.
Okay, so when you say barriers, you mean
Condoms, dental dams, female condoms, finger cots.
Okay.
Okay?
All right.
Thanks, Teresa.
Thank you so much. Nice meeting you. Bye-bye.
The challenges, I tell you, they fall on the housing. I wish there were more subsidy programs to help the homeless, and that's one of the main issues. It's just the housing, lack of funding, especially for families, that are in the reunification process, and also for single individuals. It seems very difficult for them to get placed. So I'm just hoping that somewhere there's some funding or federal laws will change and help the individuals that are in most need, because that'll help to stable them. And once they're stable, everything else falls into place.
In America, when we define addiction as a disease, we say, here's what we'll do. Let's build hospitals and treat people. In fact, the United States budget in social services has gone from encouraging employment and housing, on the one hand, towards encouraging specialized addiction treatment, which is exactly the wrong way to go. What if you take a guy from the inner city and put him in a hospital for a month, and he quits using heroin, and then you say, okay, bye, and he goes right back to the streets where he used to live? Everybody knows what's going to happen. If instead you're able to encourage that person to develop an ability to work, to become part of a community, to perhaps settle down in a permanent relationship, to perhaps become a parent, those are the mechanisms which are most guaranteed. They're slow, they're difficult, they're expensive, they're comprehensive, which is why America hates them, because we don't think in terms of social solutions. We like to think, well, let's have a medical solution. So that's the single biggest danger confronting harm reduction is the misbegotten belief, oh, they're discovering great things in medicine. What we'll do is we'll use those medical solutions and we'll discourage people from being heroin addicts. Boom. In fact, that investment in medical solutions as opposed to social solutions in people's lives is a total misappropriation of resources and completely ineffective for addressing society-wide issues of addiction.
We would definitely like to add housing to our vision of our new headquarters. First of all, there certainly is not a lot of housing on the Lower East Side for those with HIV and AIDS and those who are in a harm reduction setting and therefore have not been required to be abstinent, but those who have expressed a desire to begin to make changes in their life. And so we are exploring what kind of housing, presumably fully supported housing, which could in fact be put in place and allow a person, as they become more self-sufficient and are able to increasingly engage in independent activities, to live in supported housing, but then ultimately to go on to the next phase of their lives and have the space then be available for others who need that immediate housing and that transition as they come to full self-sufficiency.
Starting with giving them a place to live. It's going to be a big help. But of course, Alan Marlett, who died, I believe in 2012, he did a big study with street alcoholics, and what they did was they tested the efficacy of wet housing. Wet housing is where you allow an alcoholic to live someplace and to drink. And they figured, gosh, it's going to cost us less money because those guys use up a tremendous amount of resources falling over in the street. They're hospitalized. they found in the first 6 months they cut public expenses in dealing with them by half per alcoholic. But then they found out something remarkable. They were still alcoholics, they weren't social drinkers, but they cut their drinking by a third too. Because if you put a guy in a comfortable, warm place and you say, if you want to drink, you can drink, as a rule, they cut back their drinking. They didn't need to drink as much, they didn't feel impelled to drink as much, they didn't have the motivation to drink as much. As I said, they weren't wine drinkers, they only knew one way to drink, but they actually cut back their drinking as well. So what's that say? Give people a warm place to live where they're homeless, and odds are that in and of itself will reduce their likelihood of addiction and increase their likelihood of remission.
For me, the Lower East Side needle exchange program back in the early 90s was one of my first points of contact with harm reduction. I may have been reading about it, I've seen some of it in action in Europe, but I was teaching at Princeton late 80s and early 90s, and I needed to show my students. So one time we went down to Philadelphia, and what was his name, Jean-Paul Hammond, who's no longer around, was doing that, and that was a real eye-opener for my students, and even to some extent for me, just seeing people lining up there. But I remember taking my students once or twice down to the Lower East Side Needle Exchange in the early 90s, when it was on, I think, Avenue C maybe. And just once again, it was a spectacular opportunity, especially for some of my white middle-class students, but even some of the African-American students to, to see an injecting drug user not as this other figure and as this junkie or demon, and then seeing people from all walks of life, people dressed like I am, or people really messed up or whatever, people with kids, and to see people, and actually some of them would volunteer to actually hand out the syringes and the kits and all this stuff, and it was a very kind of personal, transformative thing. So I've always felt this kind of connection with that program. I remember, I remember one of the other people, I don't know if he was involved with Lower East Side harm reduction, Rod Sorge, who was an early leader in this in New York City and died many years ago, but also somebody I had brought out to Princeton to speak to my students back when harm reduction was just barely getting going in New York and a few other places. So I'm very, the role that Lower East Side has played as a leader in harm reduction over the last 20 years. I mean, now there's many more programs and a great expansion, but it's been a very important center. And the fact, and seeing Alan Clear move from Lower East Side, needle exchange program to running Harm Reduction Coalition, a national organization, and providing the sort of leadership he has, it's also nice to see that sort of evolution happen in this movement.
My vision for the future of LES is that we can in fact remain in the forefront as a pioneer. Because if you look back to the beginning of LES, we were a pioneer in identifying a need and responding to it. But it's not as if the needs have stopped. The needs have changed. New needs have emerged. And it is incumbent upon those of us who have the strength and the moxie to get out there and say, here are the needs, and we're not afraid to buck the mainstream. We're not afraid to be on the margin, but we know that the strategies that we've engaged in and that we're proposing are effective. Effective public health strategies, effective strategies for engaging people and demonstrating that there are other ways of engaging their behaviors, modifying their behaviors. And so that's where I see us going. We live in a building on the Lower East Side which is extraordinarily cramped for us. And so one of the main things that we're looking at now is finding a new home, finding a home that will have enough space for programming now and as we grow in the future, a space that can in fact be made amenable and welcoming for all our participants, and that really will provide the array of services and actual space that we need to address our participants. So that's the vision.
Lower East Side Harm Reduction Center is definitely a place that people should know about more. I know it's a small place right now in Chinatown, but the work we do is just, I feel like it could change the world, Well, not the world, but let's say New York.
I can't change the world.
Yeah.